This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal BMJ Open, published in 2026, titled Days Alive and Out of Hospital After Burr-hole Drainage for Chronic Subdural Hematoma, a national cohort study using hospital episode statistics in England.
This is a timely paper, Ilara. Chronic subdural hematoma, or CSDH, is becoming a bread-and-butter pathology for us as the population ages. While burr-hole drainage is our standard surgical intervention, our traditional ways of measuring success are often quite narrow, usually just looking at 30-day mortality or a quick snapshot of the Glasgow outcome scale.
Exactly, and that's where this study steps in. The researchers investigated the utility of a relatively new metric, Days Alive and Out of Hospital, or DAOH. They used the Hospital Episode Statistics, or HES, in England, to create a massive national cohort.
It's an interesting shift in perspective. For our listeners who might be more focused on technical operative nuances, why should we care about DAOH specifically for the CSDH population?
Because DAOH is a composite outcome. It captures the entire patient journey. As the study notes, it evaluates the validity of the metric by looking at how much time a patient actually spends in their own environment versus being stuck in a hospital bed or, unfortunately, passing away. In CSDH, we often see a revolving door phenomenon, readmissions for recurrences, infections, or secondary complications. DAOH reflects that reality better than a simple survived-died binary.
I noticed the paper specifically focused on burr-hole drainage. By using the HES data, they were able to look at this on an organizational level. That's a key distinction. They weren't just looking at individual patient factors, but how different hospitals compare.
Right. One of the primary objectives was to examine how the DAOH metric compares to its constituent outcomes, specifically mortality and hospital bed days, at that organizational level. The study wanted to see if DAOH actually provides more information than just looking at length of stay and death rates separately.
And it's a rigorous approach. By validating the metric within a national CSDH cohort, they are essentially arguing that DAOH should be a standard benchmark for neurosurgical quality. If a hospital has a high mortality rate but low bed day usage, or vice versa, the DAOH levels that out into a single patient-centered figure.
It's a more human metric, isn't it? For an 85-year-old patient, being alive but spending 80 out of 90 days in a geriatric ward isn't the same as being home. The paper dives deep into the utility of this. It helps us understand the burden of the disease on the healthcare system as well.
Let's talk about the data source. Using hospital episode statistics in England provides a level of scale that's hard to achieve in smaller institutional studies. We're talking about every patient in the country undergoing burr-hole drainage for CSDH. This eliminates the center bias we often see in papers from high-volume academic units.
And because they are using national data, they can track a patient even if they are readmitted to a different hospital. That's a critical point. If we only look at our own institutional data, we might think a patient did great because they didn't come back to us, but DAOH calculated via HES would catch if they were admitted elsewhere 2 weeks later.
Exactly. Now, the paper evaluates the validity of this metric. In the context of this study, validity means that the DAOH score actually correlates with the clinical reality of the CSDH recovery process. If the DAOH is low, it should accurately reflect a complicated postoperative course.
And it seems to hold up. By comparing DAOH to mortality and hospital bed days, the researchers could see the nuances. For example, some organizations might have similar mortality rates, but vastly different DAOH scores, because one hospital is much more efficient at getting patients rehabilitated and back into the community.
That's a vital point for residents and fellows to understand. Our job doesn't end when the burr-holes are closed and the drain is out. The goal is the restoration of the patient to their baseline environment. This paper suggests that DAOH is perhaps the best way to measure if we are actually achieving that.
It really challenges us to look at the hospital bed days component more critically. Are we keeping CSDH too long, or are we discharging them too early, leading to readmissions that ultimately lower their DAOH?
It's a balancing act. In conclusion, this study from BMJ Open provides a robust framework for using DAOH as a primary outcome measure in neurosurgical research, specifically for chronic subdural hematoma. It moves the needle from did the patient survive the surgery to how much life did we give back to the patient outside of the hospital walls.
A very important distinction for the future of our field.
Well, that's all the time we have for today. Thank you, Dr. Ilara, for walking us through this national cohort study.
My pleasure.
To our listeners, we'll see you next time on the Neurosurgery Hub podcast. Stay sharp.